In this video, we are going to talk about anesthetic consideration related to hyperthyroidism. So let's take a history. 54-year-old female patient. She came with a large thyroid swelling. She's being posted for subtotal thyroidectomy. Now, what are you going to look for in a patient with thyroid swelling? We will assess the size of the thyroid gland, okay? The tracheal deviation or compression, how much the gland is compressing the trachea, okay, or esophagus, okay. Then you have to look for the reports, thyroid function test, the T4, T3 and TSH levels, associated comorbidities, in the patient, retroesternal extension, So whenever you are taking the history of a patient with thyroid swelling, you need to look at these points. And last, not to forget, vocal cord mobility. By indirect laryngoscopy. You may ask about the symptoms that the patient is having, like difficulty of breathing, okay, or difficulty in swelling, that is dysphagia, which may be occurring prior to the dyspnea or difficulty in breathing, since trachea is always having a cartilaginous support, cartilaginous rings, but esophagus is muscular and is easy. In hyperthyroidism, we will get T3, T4 levels high and TSH levels low. You should also ask the patient about the change in voice. Or history of hoarseness. Now let's see what are the causes of hyperthyroidism. First is Graves' disease, then thyroiditis, then toxic nodular goiter, toxic adenomas, stroma overi, iodine induced, side effect of drug like and irradiation thyroid. Now let's quickly revise what are the normal thyroid values of free T3 level is 2.8 to 6.9 milliunit. Of free T4 level is 10.3 to 24.5, 0.5 to 4.5. All these values are in unit, milli unit per liter. So you have to remember this. So in case of hyperthyroidism, TSH level will be low, T4 level will be high. In case of hypothyroidism, in primary hypothyroidism, the TSH level will be low. In secondary, TSH level will be low, as well as T4 level is also low. But in case of primary hypothyroidism, TSH level will be low, TSH level will be high, and T4 level will be low. So while doing PSE, we will assess the pressure effects. Look for any dyspnea, stridor, Tracheomalacia. To check whether the gland is compressing the trachea. In esophagus, we will see or ask the patient whether the patient is having difficulty in. Ask for any history of hoarseness to see recurrent laryngeal nerve. Look for signs and symptoms of hypothyroidism and hyperthyroidism. See the reports of thyroid hormones, thyroid function test. Look for associated syndromes like MEN 1, MEN 2A, and MEN 2B. MEN 1 has pituitary adenoma, parathyroid hyperplasia, insulinoma. MEN 2A has medullary thyroid cancer, pheochromocytoma, and these syndromes are just for completion, but most important is retrosternal extension, which you should never forget to examine. So how will you examine? The book says that you won't be able to get under. For this, you have to start palpating the thyroid gland and come into the sternal. Also look for associated dysphagia, dyspnea, or SVC obstruction or thrombosis. Also look for thyroid malignancies in the patient. The type of thyroid malignancies like papillary, follicular, medullary, anaplastic, and metastasis. So in PSC, we'll be looking at the pressure effects, any hoarseness, TFT, associated syndrome, retrosternal extension, and finally thyroid malignancy. Let's move to the sign and symptoms in hyperthyroid patient. Let's look at the eye signs first. There are many eye signs. The three most important: Dalrymple, Geoffroy's, and Von Graves. In Von Grave, you will get the lid lag of the eyelid. In Dalrymple, we will get the staring look. And in Geoffroy's, you will get absence of wrinkles at forehead. You will get tremors, higher pulse rate, weight loss. Cardiac manifestations like atrial fibrillation, tachycardia, mitral valve prolapse, and ischemic heart disease. Menstrual abnormalities, pretibial myxedema, osteopenia, and exophthalmos. In menstrual abnormality, you can remember amenorrhea, for exophthalmos and pretibial mixed edema. Thyroid hormones, excessive thyroid hormones will stimulate the fibroblast. The fibroblast cells will produce more glycosaminoglycans, which have a tendency to hold water and which will lead to pretibial mixed edema as well as ophthalmopathy called exophthalmos. The cause for osteopenia is increased thyroid hormone levels leads to there will be increased activity of osteoclast than osteoblast, and hence the patient will be more prone to fractures. Also, the patient will be having mood irritabilities, and hyperactiveness. Also, thyroid hormones increase sensitivity to catecholamines, and increase beta receptor activities, and that's why patient will be having tachycardia. Also, increase cardiac output, increase stroke volume, and decreased systemic vascular resistance. We know that before taking the patient into the OT, we have to optimize the patient. We have to make the patient euthyroid first. And for that, what all drugs we can use? There are three main antithyroid drugs, that propylthiouracil, carbimazole, and methimazole. All three inhibit the enzyme thyroperoxidase. So they are thyroperoxidase inhibitors. Additionally, propylthiouracil has an additive action of inhibiting peripheral T4 to T3 conversion. Also, propylthiouracil is safe in pregnancy because it do not cross placenta, while methimazole is known to cause teratogenicity. If they ask the doses, you can remember as for propylthiouracil 100 milligram 8 hourly since it is shorter acting, carbimazole 15 to 40 mg per day, and methimazole 10 to 30 mg per day. They both are longer acting and propylthiouracil is shorter acting. Another drug that we will use is propranolol. Why we will use it? First, to decrease palpitations, high heart rate, tachycardia, and additionally it also has the same function of conversion, inhibiting peripheral conversion of T4 to T3. It is given in dose 20 to 40 mg 6 hourly. Next drug that we can give is dexamethasone 2 milligram 6 hourly. This also decreases peripheral conversion of T4 to T3 and decrease hormone release from the gland. So at least 3 to 4 weeks prior surgery, we have to start this management. Antithyroid drugs are first line in this. Also after 4 weeks, we have to repeat TFT. You may get a question like, what are the side effects of antithyroid drugs? So the most common important is granulocytosis, hepatotoxicity, vasculitis, and teratogenicity. Earlier they used Lugol's iodine also, but nowadays it is not practiced. Okay, so main drugs that we need to remember is propylthiouracil, carbimazole, methimazole, propranolol, dexamethasone, and for completion, Lugol. Now we will see the physiology part, how thyroid. It gets signals from hypothalamus. Hypothalamus releases thyroid releasing hormone, which stimulate anterior pituitary to release TSH, which will stimulate the thyroid gland. So there are total 4 steps. First is iodine trapping. Second is oxidation reaction. Third is organification, and fourth is coupling reaction. So the iodide iodide, we eat iodine and we get this iodide from GIT, which will enter the circulation, and around 20% of it will enter the thyroid follicle. This is the thyroid follicle. This is the luminal membrane. This is the lateral, and this is the basal side. So through basal side, there is one pump called sodium iodide symport pump, which will allow the iodide ion to pass through it via secondary active transport. Okay. So iodide ions will come here. This step is called iodide trapping. Iodide ions are trapped in the follicle. Now they will undergo oxidation and will get converted to iodine molecule. This reaction will happen with the help of one enzyme, that is thyroperoxidase, which is present on the luminal membrane of the thyroid. Also, there is one more protein which will be formed by nucleus of thyroid follicle, that is thyroglobulin. Thyroglobulin is made up of various tyrosine residues. So we have seen the second step also. This was the second step, oxidation. Now organification. Combining of this iodine molecule with thyroglobulin is organification. The iodine will combine with the tyrosine residue of thyroglobulin, and if such molecules will combine, that will lead to coupling reaction. So in this way we will get T3 hormone and similarly T4 hormone. All these reactions will be happening in colloid. And one reaction, that was iodine trapping, happens inside the follicle. Now let's see the important investigations that you will order in this case. First is we will order CBC, regular CBC count, check for any anemia in the patient. Next is RFT, serum electrolytes. What all changes we will be seeing in serum electrolytes? In potassium, sodium, and calcium. Sodium and potassium will be decreased and calcium will be slightly raised. These are decreased due to water loss in the patient, diarrhea and vomiting, all those symptoms. Next, thyroid function test. In thyroid function test, we have already seen that TSH will be low and free T3 and T4 levels will be high. Next is you would like to advise X-ray neck or CT neck. Okay, X-ray you can see AP, lateral, both views. And why we are seeing CT neck? To check the extent of the swelling, to check the extent, to see tracheal diameter, if it is compressing or not. Okay, extent, we mean retroexternal extension. What is retroexternal? 50% of the thyroid gland is in thorax. So retroexternal is when 50% of the thyroid gland. If the report says that the trachea is infiltrated, like it is having malignant infiltration, okay, or intraluminal extension of the mass, then you may have difficulty in passing ETT, endotracheal tube. By seeing CT neck, you can also plan your anesthesia, since there are three main approaches. Like if it is up to aortic arch, the surgeon can do the surgery through cervical approach only. If it is below aortic arch, then they may have to do manubriotomy. And if it is below right atrium, then they need to do sternotomy. Now we will discuss how to induce the patient. We can induce by giving general anesthesia to the patient or cervical plexus block or cervical epidural, depending on the skill of the anesthetist. But most preferred and most common is general anesthesia. Also, we have to keep difficult airway cart ready, which should have all sizes of airways, mask, ETT, video laryngoscope, fiber optic, bougies, rigid bronchoscope, and also tracheostomy set. Okay. What monitors will we using? We will use 5 ASA standard, ECG, NIBP, saturation, temperature, and other things like you can do urine output monitoring, neuromuscular monitoring. And if the patient is having any cardiac issue, then invasive arterial, you can take an arterial cannula and do beat to beat monitoring. And yes, ETCU too. Always use temperature probe in these patients so that you can always have a look. Okay, there is no complication like thyroid storm. After pre-oxygenation, we will give IV anesthetics to the patient. You can use thiopentone, propofol. Thiopentone is preferred in thyroid cases. If you want to check out my playlist on drugs, I will ping it. Make sure that you keep the planes deep enough. Okay, and you should suppress the intubation response because already the patient is tachycardic. Intubation or stress response, you have to decrease it. You can decrease it by giving IV lignocaine or Dexmed or esmolol. You can use propofol, but you have to increase the dose slightly because it has rapid due to high metabolic. You cannot use ketamine in these patients. Okay, not at all. It stimulates the sympathetic. Again, you can check out my video. Now for maintenance, you can use either SIVO or ISO. Okay. In muscle relaxants, we can use vacuronium, rocuronium, or if you're finding some difficulty in intubation, succinylcholine. Okay, but never use pancuronium for the same reason that it also stimulates sympathetic system. For reversal, we will give glyco plus neostigmine. Since there is always chances of kinking, we should use flexible or flexometallic endotracheal tubes. Okay, because there are also chances of tube dislodgement, very common in these. For analgesia, we can give paracetamol, opioids, superficial cervical plexus block. There can be some possible complications in thyroid surgeries like recurrent laryngeal nerve injury. It can be unilateral or bilateral. In unilateral, patient will be having hoarseness, but in bilateral, patient may have stridor, difficulty in breathing. Then you have to do emergency tracheostomy. Okay, and always check vocal cord mobility at post extubation. Okay, so post extubation, you should check vocal cord mobility. Or before extubating the patient also you can check by doing direct laryngoscopy. Hematoma is the complication, tracheomalacia is the complication. Hematoma can occur up to 6 hours and thyroid storm can occur up to 24 hours. Also bleeding can also occur. Okay. To check tracheomalacia, we do cuff leak test. So what will we do? This is the cuff of the ATT. So we will deflate the cuff. So there will be air leakage. Okay, which is positive that there is no tracheomalacia. Okay, so if a leak is present, then it is good. So they say that up to 111 ml of tidal volume of air should leak to get cuff leak test positive. And lastly, few lines about thyroid storm. This is a emergency situation. It can occur 12 to 18 hours post surgery. Okay, and how it precipitate? We know that any stress situation, okay, like surgery, trauma, all these can stimulate thyroid storm. And one drug which they can ask is amiodarone. What are the DDs of thyroid storm? You have to remember malignant hyperthermia, neuroleptic malignant syndrome, and pheochromocyte. You will get symptoms like tachycardia, hyperthermia, hepatic failure, arrhythmias, congestive heart failure, coma, nausea, vomiting, diarrhea, delirium, psychosis, etc. And then you will manage by lowering down the high hormone levels by giving propylthiouracil. You can give it by NG tube. Then you have to treat the hyperthermia by externally cooling the patient. You can set the tachycardia by giving propranolol, IV propranolol. You should also give steroid cover around 100 milligram IV hydrocodone you can give, and you have to give lots of fluid since the patient is losing fluid from here. Nausea, vomiting, diarrhea. Okay. All right. So if you want more such content, please subscribe to my channel. Thank you so much and happy learning.